fondly called as MS Sir, is a senior consultant, cornea and refractive services at Aravind Eye Hospital, Madurai, and he is a Director-Emeritus. He is one of the founding members of Aravind Eye Care System, joined the organization as a medical officer in Cornea Clinic in 1981. He headed and developed the Cornea Clinic. He is a director of Aravind Integrated Eye Bank Services. He is a lifetime member of All India Ophthalmological Society, Tamil Nadu State Ophthalmic Association, National Society for Prevention of Blindness, and Eye Bank Association of India. Throughout his career, he has conducted several research studies, both clinical and epidemiological, including drug trials. He has also conducted several WHO-sponsored population-based studies. The evidence from these studies has shaped the way diseases of the cornea are being addressed across the developing world. He has published several papers in peer-reviewed journals and got several awards from various ophthalmic societies and associations. He has been named in the list of world's top 2% scientist ophthalmologists published by Stanford University study in 2020. Over to you, sir.
Thank you for your introduction, Doctor. I would like to thank Dr. Manohar Babu and his team for inviting me to participate in this CMA. I think I'm sorry I could not come physically to attend this meeting. So far, people are hearing about commonest extraocular disease and lab diagnosis. So now I will move on to corneal ulcers. So the title was corneal infections, corneal ulcer. Mostly I will deal with various different kinds of corneal ulcer. So first thing is magnitude of the problem. Now the world population is 8 billion. You get about close to 1.6 billion corneal ulcers every year, mostly in Southeast Asia. In India alone, we see about 1 million corneal ulcers every year. So in those days, the commonest cause of corneal blindness was trachoma. Everywhere this was one frequently seen, and more in North India and Africa. South India, even my student days, I have never seen a trachoma case because facial cleaning, facial washing, and shower, everything is common in South India. And this is almost eliminated except in some parts of Africa. India, I don't see now. Then again, the gonococcal conjunctivitis, we don't see now. So most of the deliveries are hospital-based deliveries. And after Keratitis method, you don't see gonococcal conjunctivitis. Very rarely you may get sometimes vaginal herpes or something like that, not gonococcal. And vitamin A deficiency, keratopalacia, after this nutritious meal system, the government programs providing nutritious meals to kids. Also, lifestyle change, and we are in better position. We don't see any really poor patients or poor people now. So keratopalacia also, and whenever you see some terophthalmia, it may be due to some other problem, not breastfeeding or some other medical conditions. Then many postgraduates and fellows, I used to show this slide and ask them to diagnose, and mostly they don't because they have not seen. So this again commonest cause was corneal blindness, smallpox. We don't see it now. It's all eradicated. But currently, frequently, the predisposing factor for corneal ulcers, not only in India, developing countries, trauma. In India, trauma means it's not like road accidents or perforations, trivial injuries. It's about 50 to 80%. You get corneal abrasions, micro, macro abrasions, then it predisposed to corneal ulcer. Fortunately, contact lens wear is very less. Then, see, when you see these patients, mostly busy ophthalmologist, in his practice is busy. He may get 1 or 2 cases like this every week, mostly like this, maybe every day in places like Coimbatore, Salem, a lot of lathe works, you will get like this. So this one is a small fragment of wooden branch or splinter, no inflammation, but routinely I remove a slit lamp and place in a KOH smear, and you can see the fungus, even though there is no inflammation. But here, most of the time, I will say about 90%, they don't get fungus. You get rust, infiltrate, mostly bacterial. So you should think vegetable matter, wooden branch, think of fungus. These foreign bodies like iron rust, stone particles, like cracker injuries, blast injuries, mostly they carry bacteria. The pathogens responsible for bacterial in Western countries, more than 90% bacterial, maybe 10% fungal. But totally the revert side is fungal is more common in India, not only in India, Southeast Asia. Right now, Aravind, we have, last year we have seen totally about 8,000 corneal ulcers. In that, 70% fungal, proved fungal. Parasitic, again, acanthamoeba is not so common. It's mostly about 1 to 2%, few in contact lens wearers. Others, rare organisms, I will show you later. So again, normal flora, this has been discussed. All our even no conjunctiva without any infection, inflammation. In adulthood, most of the people will harbor Staphylococcus epidermidis, sometimes aureus, rarely Pseudomonas, Candida like that. This is a normal flora. And for bacterial ulcer, these are the pathogens you see frequently: gram positive Staphylococcus and Pneumococcus, gram negative Pseudomonas. In Mycobacterial nocardia, in India, I think we have reported up to 10% of corneal ulcer, bacterial ulcer due to nocardia. But in Europe and US, they don't get this. Then again, atypical mycobacteria also you should think about. It's rare, but we see more now after refractive surgery, particularly PRK. After PRK, many people they come with infiltrate. After 4 or 5 weeks, you should think about this atypical mycobacteria. Then about fungus, this paper published from Tirchi Joseph by Leck and Thomas, you see that percentage increases and the latitude is like this. So close to equator, you see more. So patients, we all live close to equator, so most of our corneal ulcers are fungal. If they are away from equator cold places, mostly they don't get fungus. Then care of patient with corneal ulcer, historical. Maybe this is just for you just to remember or recognize that in those days when we were medical students or even when we did post-graduation, we didn't have all antibiotics. We had only chloromenicol and sulfositamide, nothing else. No fluoroquinolone, no aminoglycosic acids. So we used to have in the OP silver nitrate 1%, boric acid, mercurochrome, iodine, and for fungal we used to give fewer therapy. You autoclave the milk, then we give IV to induce more antibodies. That was a treatment. Then oral antifungal, the tablet given for dermatitis we used to give. And most of the patients admitted, then there was no specific treatment. There was no ocular microbiology. It's all general microbiology. Mostly they are busy with other major infections. Current protocol at eye hospital, preferred practice pattern, even now, I think this week, the AAO, they have published this preferred practice pattern for bacterial, mostly for bacterial ulcer. How will you go about? And every one of you should go through that. We also have the old one, and broad spectrum antibiotics. So now you have powerful antibiotics to cover any bacteria. So you need not go for formulated antibiotics like concentrated antibiotics. And you have newer antibiotics and newer antifungals. The diagnosis conventional, I still I believe in lab diagnosis as an academician and academic institute. We always subject all the simians for lab diagnosis. But every ophthalmologist, you should master your clinical skill to diagnose corneal ulcer, either it's bacterial or fungal. In India, it's crucial to differentiate at day one when you are seeing the patient at slit lamp. You should be able to tell, you should be able to commit you are dealing bacterial or fungal. But if it is in US and Europe, they need not worry about that. They usually treat as bacterial, but here you have to differentiate. Otherwise, you will end up in gross negligence and you will lose eye. The modern investigation is all described by Dr. Ram. So this clinical pneumococcal infection mostly involve like compromised cornea, like old CDK or band cuttopathy or leg ophthalmos, lid infection. But mainly you should look for Director-Cystitis. From Trichy, they have published 50% of corneal ulcer associated with Director-Cystitis harbors pneumococci. So if the duct is not free or you do Roplas, you get discharge when you press, it's always pneumococcal. You just go ahead with all your lab tests, but you start the treatment for specific for pneumococci. Then if it's Pseudomonas, we don't see like this. But teaching was, it's called Pseudomonas, it's a pyocyania. The pus is greenish blue. That's what's a typical clinical feature of Pseudomonas ulcer, but you don't see such a severe ulcer nowadays because you have powerful antibiotics. But patients infected with Pseudomonas usually have severe lymphedema very fast. Within 2 days, it may kill the cornea and a lot of discharge. So you should think about fungal, you never get this. So these are the reliable clinical signs to diagnose bacterial ulcer. First, you look even very few days, suppose following a trauma or something exposure to some toxic materials, patient will come with little lymphedema watering, and always routinely we syringe the duct, but at slit lamp I just press like one say, you get like this. So it's definitely bacterial, definitely pneumococcal. Like this, hypopion, answer like this with dense infiltrate at the progressive end is the receding end. Again, you should suspect pneumococci. And well-defined lesion like this, hypopion, lymphedema, chemosis, discharge. Again, it would be gram-positive, staphylococcus, streptococci. And this one, it's a college student after contact lenses. I know he was on college tour. 2 days he has not removed the contact lens and he landed like this. When you see this mucus-like discharge, again, marked congestion, chemosis, you clean the discharge at slit lamp with a sterile cotton swab. Now, after 5 minutes, it again collects like this. It's a strong evidence or clue to diagnose Pseudomonas. It's definitely Pseudomonas, but gram stain will prove. But in a fungal ulcer, even severe ulcer more than 5 millimeter, inflammation is less. But see the edges. Always look for the edges carefully. Most of the time, you will have these finger-like projections, feathery borders, and dry-looking ulcer. So all these are bacterial. Top 3, this is fungal. Then fungal early things, it will mimic like a dendritic ulcer. Even today, my consultants mostly, when they see this, they start antiviral. Yes, cyclovir they give. Sometimes they give steroids. Then look at the patient after a week, then they come with a severe fungal ulcer. So fungal ulcer early is a very typical sign. Minimal inflammation and no adjacent scar or vascularization. This is dendritic ulcer, fungal, and see again the border, whatever size of the ulcer. Look at this fungal ulcer border and bacterial ulcer. It's a staphylococcal ulcer. Again, look at the borders of fungal ulcer. See, conjunctiva is white, same time it's a pneumococcal ulcer. You see the discharge like this, it's always Pseudomonas. That's what I treat. Then early perforation, you will see the radial folds. Chamber may be shallow, may not be shallow. Here, I don't know. Somehow you have to get the specimen for smear and culture, but this is perforating. So once you confirm the diagnosis, you start the treatment, or some people use glue, bandage lens, all those things. Then pigmented fungal ulcer, very easy to diagnose, very difficult to scrape. You have to really use Kimura, everything will not work here. Really use 15 blade, you should chop like keratectomy, then only it will come. Sometimes it may have a mixed infection, pigmented fungi. Takes weeks or months to heal. And the regular natamycin amphotericin B will not work here. You have to go for ketoconazole or becconazole. This also we get 14% of our fungal ulcers are due to pigmented ulcer. Suppose if bacterial selection of topical antibiotics, now we pick up broad spectrum to cover gram-positive and negative. Macrolides, azithromycin, clarithromycin usually doesn't cover streptococci or staphylococci or pneumococci. So polypeptides, aminobutyric acid is the best drug, either gentamicin or tabromycin. Amikacin specifically for nocardia and mycobacterium. This any one you can choose. It covers both staph epi, staph aureus, and also Pseudomonas. Fluoroquinolones, second generation, third generation, fourth generation. And several papers about microbial resistance to fluoroquinolones. So in vitro, it may show 20%, 40%. Sometimes I think Prasant Garg has published Pseudomonas about 80% like that. I believe it. But practically, even I get in vitro resistance to particular antibiotic. When you apply frequently every hour, when there is an epithelial defect, somal defect, the same medicine you apply continuously every hour like that and look for the patient compliance, always it works. If you see there is a response, you don't change the treatment protocol even though in vitro results differ from you. Off-label drugs mostly like amphotericin B, vancomycin, concentrated amikacin, cephalosporin, all are off-label, PHMB, all are off-label drugs. That also has some role here. Cephalosporin is very good drug for gram-positive. If I look for pneumococci, I usually start with this. Sometimes I add vancomycin. And unfortunately, cephalosporin, very good drug, is not available now. So we go for next generation. Then aminobutyric acids, now we don't use gentamicin much. It is very toxic to epithelium, especially concentrated drops. It gives, it looks as though your lesion is not responding, increasing because of the toxicity of the drugs. Tabromycin is better. Fluoroquinolones, if there is a corneal foreign body, iron or rust or stone or something, I remove it, I give ciprofloxacin. Cipro still works even though papers are, they are not recommending for lab employee appears within 1 or 2 days, you remove the foreign body at slit lamp with a sterile needle, 30 gauge or 27 gauge needle, sterile needle, throw the needle, don't use spud. Then you give ciprofloxacin, apply 4 to 6 times, they are fine. But now the trend is, I think, maybe I call fancy trend. Everyone they get Vigomax for 300 rupees for nothing. Cipro will work. Or you go for ofloxacin, Moxie, you can use it. But Moxie and all powerful Getty, levofloxacin concentrated. You reserve it for severe infections, not for just small ulcers. Again, only use monotherapy or combination, depends on the size of the ulcer. Suppose patient has already used monotherapy, any of the drugs, treated outside, referred to your institute, then check the medicines whether they are really applied or not. When it doesn't work, you still think it is bacterial fungal, you change or add some combination. And don't combine bacteriostatic and bactericidal, always combine bactericidal. Then frequency, theoretically every hour, waking hours, and bedtime we give some broad spectrum antibiotic ointment. But practically it is not possible. Many patients, even office going people or laborers, they don't sit at home and apply every hour unless it is severe ulcer and painful. That's why some of the cases, if you see you are treating with correct diagnosis, you have made correct diagnosis, treated with specific antibiotics, still not responding. If possible, admit the patient 1 or 2 days and see that he is getting the drops frequently and look at the response, then you can discharge. Many times I have seen it's not possible to apply every hour for working class. So Acupal has combination, chloromenical and polymyxin. Polymyxin is good drug for gram-negative. Chloromenical, it covers gram-positive, most staph aureus, staph epi. Then tobramycin, Araflox, the Moxie, Levo, Getiflox, Pisciflox, almost all are same. And gentamicin I don't use now, I was using. Sometimes it is toxic. And that is higher concentration levofloxacin. Now they have marketed 1.5%. If you want, you can use. Never combine. Suppose patient has used one fluoroquinolone on one kind, not responding, you don't go for another fluoroquinolone. You have to think about revise the diagnosis, change the antibiotic. This is the guy, college guy, Pseudomonas, 3 days. So visualaxis looks so severe. So I just started. So when I see a corneal ulcer, bacterial, I go for 4th generation fluoroquinolone unless it is gram positive. And I'm sorry to say most of the Indian antibiotics, moxifloxacin, made in India, even by Allergan or Alcon, I think it doesn't have similar effect as its imported one. Maybe stability, raw material they use, I don't know. But this, I prescribe Vigamax, then the 3rd day, the 7th day, completely heals. Then once it heals, you don't stop immediately, at least recommend them to apply 4 times a day for another week. If it is fungal, you have to continue for another 2 weeks. If it is acanthamoeba, at least for 4 weeks. So here I don't try this, that. So strongly hit with Vigamax or the Allergan product. There is Getty also, it is available. The Indian Moxie, even though produced by same international company, it doesn't cover. I don't know, there may be various reasons. So even severe Pseudomonas ulcer, start Vigamax every hour, nicely heals. But sometimes Pseudomonas, you are treated, now you have made the ulcer sterile, you do repeat culture, you don't grow anything, but the hypopion doesn't disappear. This is purely inflammation. In these cases, under cover of your antibiotic, you give steroid, prednisolone acetate or prednisolone phosphate or dexamethasone 4 times a day for a week, then a taper, it nicely heals. Otherwise, you wait for a month, this epithelial defect doesn't heal, the hypopion doesn't disappear. So Pseudomonas ulcers, even severe ulcer, you're treated for a week, sterilize the ulcer, still you see these things, I don't hesitate. I just start steroids. We have proved in SCUT study, even in Pseudomonas ulcers, steroids will help to reduce the inflammation. Then actinomyces, really I don't see corneal ulcer due to actinomyces. You will get canaliculitis, very common. Nocardial ulcers, we get about 10 to 11% of our ulcers are nocardia, and we have also published in SCUT study. And so you know that Dr. Ram has shown you the picture. Nocardia, easy to diagnose. So this kind of pinhead appearance, I can't read superficial. If you see like this, like a, like a Trantas dots in VKC at the limbus, you see like this, 100% sure it is nocardia. You can do lab work, but why you get this kind of pattern, I don't know. And the culture, you will get this coral, like thing, very, very rough surface, orange or golden, and the gram stain you will see, or acid fast, you will see the nocardia. Here, fluoro will not work, even though some papers they claim Cipro and all those things work. I don't believe that. Here you use sulfacetamide, 20% it's available, or straight away you start 2% amikacin. Topical amikacin, commercial available 1%. Two companies are making Aminogen and Amikan, but we use 2% amikacin. Instead of oil preparation, amikacin available as water soluble, 100 milligram vials. It's a pediatric one. You can dissolve, make it 2%, some people 4%. It definitely responds. It doesn't respond to other medicines. Surgery is rare. So nocardia, this we used to see, it's called mycosis. So we noticed this only in the early 90s. Before that, nocardia, in fact, only the lower limbs, most of the patients, they come with a measure of foot. So sulfur granules, they just sprout multiple sinuses in the lower leg. Sometimes they end up with amputation. They use sulfur medicine. But in the eye, we started looking at 1990. Most of the post-op patients after cataract surgery, we used to give nocardia endophthalmitis, and we never had before then. Since 1990, we started looking at that. When you get endophthalmitis, it carries very bad prognosis, but for corneal ulcers, it heals nicely. Then acanthamoeba, radial keratitis, we rarely see because we get the patient at the later stages. This is very common clinical sign in acanthamoeba. India, contact lens is not the risk factor. So any patient coming to you, or treated by several ophthalmologists, 1 month or 2 months, still it's not perforating, and it is not, there is no descemetocele, not healing, painful, then always think about acanthamoeba. No bacterial ulcer will run for a month without perforation. Pseudomonas in a week it will perforate, other ulcers also. So if there is a corneal ulcer, not healing, not perforating, to think about acanthamoeba and do all the tests, and still there is no approved medicines. You have to go for only PHMB. The incidence, contact lens, you have daily wear less, extended wear you will have more. And in Europe, in US, this is a major problem for them. So anybody is having contact lens when they come with a corneal infiltrate, for them, the first favorable diagnosis is acanthamoeba, but India it's not true. India maybe still contact lens, mostly gram-positive, Pseudomonas, and acanthamoeba, then Mycobacterium. Currently, no drugs are licensed for use in UK, acanthamoeba. 6 are highly resistant. We still use PHMB, 0.02% or 0.04%. And we have parental solution in the lab, and they concentrate under the laminar flow hood, and we give to the patient. Fluorhexidine also, we don't combine this. Both are equally effective. Now the recent paper by John Dott or this group, they have published recently, they use 0.08%, 4 times more concentrated. They have seen higher rate of healing. So they recommend now 0.08%. And I think I think we are launching already. They have launched a multi-country study, multi-center study to start 0.08%. And itraconazole you can add. So we routinely give PHMB. It takes months, 4 months, 5 months. Then this one just theoretical interest. People are now they are interested in developed countries. Miltefosine, oral, or topical, dose is 2 milligram per kg for 4 weeks. This is already used in leishmaniasis. The miltefosine for one patient, I think as a project they have tried $10,000 for one patient. A very toxic drug. This is just for postgraduates. If you when you are writing a theory paper, you can add this, but we never recommend for the patient here. Then non-tuberculous mycobacteria. This is rapidly growing. Usually follows any surgery or injury, not in a healthy cornea. This is a patient with penetrating cataplasty. So about 2 months they do very fine. They are under steroids and antibiotics. Then they come like this. It's not purulent. It starts in one end and spreads like Alka serpens like that. It spreads like this. Chronic coats, and as it passed, you can diagnose. And he had cluster infection long back, and all my maybe half a dozen cases with penetrating cataplasty, they got this. Then we were wondering why we get this. Then we could identify the risk factor. This is in one eye donation center. The people we give instruments, and also we have recommended to autoclave or at least chemical sterilization. And this center, they never sterilize the instrument. They always carry in their pant pocket and remove the donor eyes and again same instrument. So from one donor, they have spread to several donors with the same instrument, and that was the cause for mycobacteria. Chelone and Chelone is common. Then recently we have seen after PRK. After PRK, the patient comes with pain, some infiltrate, 4 weeks or 5 weeks. After that, you already stopped your antibiotic steroids, and they come like this. You think about mycobacterium, mostly sometimes bilateral, and you start treating with amikacin. The treatment is 2% amikacin or clarithromycin. The graft always fails, and you have to go for regraft. So, if anyone is coming after corneal infiltrate, some pain, haze, post PRK, we think about this and start the treatment. And this one rarely, Burkholderia capacia, very rare. This, I think 2013-14, in one center in Madurai, is a busy, very, very high volume surgeon. All the cataract patients. This is the site of stab incision. That's the main incision for phaco. This surgeon always use maybe upper nasal and no side port. Very good surgeon. Surgery is good. For 4 weeks follow up when they come with a small lesion. Till that they are very fine, 6.9, 6.6%. Then it spreads, hemorrhagic hypopion. Then you do this for biopsy or to eliminate the infection. So then we proved it is Burkholderia capacia. The special features of this bug is you can't kill it. Even by autoclave, you can't kill it. Once you have, mostly it could be contaminated blade, even though you use sterile blade, in each case, different blade, new one, somehow manufacturing defect or some other solution they use. All these patients, I think this surgeon had about 140 infections, similar. All these patients, they grew this and response is very poor. They end up like this. This is very, very rare. If there is infection in your port of incision, particularly phaco or small incision cataract surgery, first thing, stromal infection, mostly stromal. We think about fungus and smear and culture difficult unless you do biopsy like that area, or you have to go through antechamber, or you do confocal. This one, you just have a think about this. It is very, very rare. I have not seen my lifetime. This is the one area from one center we got this. This is a rare one. Then about microsporidium. This is my friend now. This is gram stain. You can nicely see the spores. This is calcofluor white. And they come with stromal infiltrate, not like epithelial, not like other corneal ulcers having epithelial defect, edges infected like that. This is mostly like stromal infiltrate and sometimes very dense abscess. When you get conjunctivitis, mostly you get in healthy adults, in immunocompetent patients. When you get corneal ulcer in microsporidium, mostly immunocompromised. You had one case bilateral also. So this is very rare. It's not common. You need not. This is your last diagnosis. Mycobacterium, microsporidium, corneal ulcer is rare. Just you should have an idea. And antifungals, we use natamycin, drug of choice. Even today, drug of choice for natamycin is fusarium, for fusarium. So if it is fusarium, don't change the drug. If it's not healing, check the drug. Many of my patients, they put natamycin in homatropin cotton and homatropin in natamycin cotton. They apply homatropin every hour and natamycin twice a day. So please, when you see the patient at follow-up, see, you need not spend, just keep talking and all those things. 1 minute, you just collect their drugs and just check. It gives you a lot of clue. And even latest, many patients, they come with, there are drugs to apply on the skin for rheumatism, back pain. The container typically looks like ophthalmic product, ointment and drops. They apply into the eye, the signs get worse. You just check the medicine, and invariably it was at home. They thought it was eye drops. They apply, and then econazole, if it is aspergillus, you can try. It is in arachis oil or peanut oil, burning. So patient will complain it's burning. And the voriconazole, it goes with every patient. In vitro, it works for fusarium and aspergillus, but I don't believe this. I prescribe only natamycin. If it is aspergillus, I go for amphotericin B. A newer antifungal, you don't have topical. These are some of our papers, combination of natamycin and econazole. So combination of antifungal doesn't make any difference. So then pythium recently is emerging. It's not rare. Anyone can get, need not be immunocompromised. Very difficult to differentiate from fungal even by lab. Some of the clinical features will help. This tentacle-like appearance, this kind of ridge like this, then a gutter around that. It will not have like your vital ulcer, feathery borders like fungal ulcers, it won't. It will be different. Why it gets such a morphology, I don't know. Sometimes it mostly starts in the periphery. Patient will come with 6-9 vision. Then it comes towards that is centripetal spread. So this is gram stain, KOH. You'll see mycelia, sparsely septate, and variable thickness. Like, see, the diameter will not be same like in a typical filamentous fungi. So the lab people, you just insist the lab people look for pythium. And the cauliflower white also definitely helps. Otherwise, a technician usually, when they get lot of fungal ulcers, they used to see lot of smears, KOH, gram stain. They pass it as fungal. Then you start antifungal, and patient, the signs get worse. They come with perforation. And this one, collagen cross-linking, they are doing. This is too much for private practitioners or small centers. This is for academic institutes. You should have the equipment. This is for academic exercise. Many people, they are trying to prove, particularly in non-healing ulcers and resistant body ulcers. Then tissue adhesive with the microperforation, conjunctival flap, tectonic graft, full thickness, and sometimes evisceration. The latest publication from UK, from IE, the evisceration is about 8 to 10%. Out of 1 million corneal ulcers, 10 to 14,000 are eviscerated even in UK. So corneal ulcers, when you pick up very early, it do very well. It responds very well. You and patient both will happy. And don't jump, don't change the medicines. And if the ulcer is not responding, we just again revise the diagnosis, check the medications, compliance, rule out diabetes, lag ophthalmos, something. Many people may have lag ophthalmos. So you should differentiate neurotropic and infected corneal ulcers. It's also important. Sometimes congenital corneal anesthesia, children, they will come with a corneal ulcer, unilateral, bilateral. They won't have any symptoms, pain, photophobia. It will look like infected corneal ulcers, but it is due to loss of corneal sensation. See, the diagnostic dilemma of fungal keratitis, till it is there, is not easy. This is the global incidence. Now, the recent publication, even 2024, it is 1.5 million, almost 1 million. Silent. This is from Annals of National Academy. The resistance bug are emerging because we use for even minor infections, we use highly powerful antibiotics reserved for severe infections. So corneal ulcers is not rare. You see every day. Average ophthalmologist in private practice, he may get 1 or 2 corneal ulcers. So you treat them based on your clinical findings. If you see no response within maybe within a week, then refer to higher centers so that they can do or they have facilities for other investigations. Thank you.